just want to thank Dr. Weinberg, give him a shout out for allowing me to switch. Even though he went over 10 minutes, that's okay. He can have an extra 10 minutes for letting me switch. So, and remember, he'll be here tomorrow instead of me, okay? Because I'm here today instead of him for the second hour. So, basically, what we wanted to do, last time some people, they had a practical and things like that, which is fine. I understand that. I don't take attendance, and so, but if I come in here one day and there's no one here but the video camera, it might be bad, and I might just say like, well, maybe just watch last year's video. So, because the only thing that changes, obviously, I try to go over the same material. I made those little videos that has like all the the important stuff, and then what happens in the class is I try to go over sort of the same stuff, but mostly your questions make it different, right? So if there's no interaction, it's not any good. So that's why it just can't be me and the cameraman, or camera lady, I should say. But anyway, so I guess those are available on YouTube publicly, and so I'm going to go check them out just to make sure that I look okay on it. All right, so last time we did the first lecture on mandible, and what I said was that the mandible is the most complex bone in the body, and I believe that. I believe that if you look at all the bones in the body, this is the most complex bone. And I sort of gave you a way to start to think about the mandible in terms of function, in terms of physiology, in terms of growth, okay? And I said that we're going to divide this mandible into parts so we can understand it. So just quickly to review that, if we look at a mandible, and I'm going to draw just half a mandible. It has, hope Dr. J approves my tooth drawings. All right, so basically, it's not to scale, okay? There's 5 parts, and I don't always number them the same way, so don't. Okay. So there's 5 parts of the mandible in terms of your thinking. So as you're reading, as you're studying the mandible, as you're thinking about how to put all this together for the rest of your dental career, because this is the bone that you're going to be dealing with along with the maxilla and the maxillary teeth. So through the next 4 years, the idea behind giving lectures or actually even having an instructor is to provide the skeleton framework for you to learn. Okay. Otherwise, you might as well just go look at the book and figure it out yourself. Right? So I'm trying to give you a way to pack the information so that you can unpack it later. Okay? So number 4 is what? The corpus. Purpose of the corpus is what? Who remembers the purpose of the corpus? Pardon me? It's the body, and it connects the 2 sides. So it's really a structural component. And what else happens in the corpus is that the corpus is pretty inert, except for, you get a little bit of change here at the chin, in terms of deposition. You get this as a secondary sex characteristic, so, we developed that so that men could attract women, I guess, okay, and women would be attracted. Now it's changed around, so I'm not sure if the chin's changing or not, but this is the only place where that really changes is the chin. Everything else all the other growth is occurring in the other parts of the mandible. So, what about this one? This is a big one. We're going to spend a little more time on this one. What's this one called? Number 4? The alveolus. The alveolus, right. The alveolar process, the alveolus. So we said last time that the function of the alveolus is to house the teeth. So if you have a mandible that doesn't have any teeth, like you can see a couple of these here. Here's a good one. Here's a mandible that doesn't have any teeth, okay? And what you see is that you don't have really very much vertical, right? You don't have very much vertical facial height. So the vertical, the part that holds the teeth, is gone because the teeth are gone. I'll give that to Brian and he can pass that around. So when you're making a denture, you're replacing the alveolar bone and you're replacing the teeth. Okay? And so one thing that we'll always tell your patients about dentures is what? Are dentures a replacement for teeth? No. They're a replacement for no teeth. Okay? So just make sure you get that across, because people are going, hey, this is a poor substitute for real teeth. But, you know, if you don't have any teeth, it's better than that. All right, so number 3 is the big boy, right? That's the one that's the most important in terms of growth and development. It's called what? The ramus, right? So the ramus is important because that's where all the growth is occurring. All the growth is occurring in the ramus. So the ramus is the most important part of the mandible for growth. Okay, you see on the anterior border here, we get resorption of bone, right? Because we have to resorb bone on the anterior part of the ramus in order to increase arch length. We have to increase the arch length because the molar series, when teeth first come in, there's not enough room for all the teeth. So you went and saw the second graders, and I pointed out that what you want to do is put your finger in the back of the mouth on the top, and so you can see that you feel the maxillary tuberosity. Okay, in the mandible, if you put your finger back here, okay, you've got the anterior ramus. Where's the mandibular tuberosity? This is a bonus point. Where's the mandibular tuberosity? Yes. It's lingual, absolutely, that was right. If you were here last week, you remember that the alveolus, part number 4, and the ramus, if we look down, are in 2 different planes of space. The mandibular tuberosity is lingual to the ascending ramus. So it's back in here, and a huge error in dentistry for the last 50 years, maybe even more, maybe the last 100 years, not quite 100 because we didn't have x-rays, 1930 or so, 1920. So I guess it would be almost 100 years now, right, next year. So a huge error is this. Most of the x-rays that we take for dentistry had the x-ray beam coming this way in the mandible, and it used to show the mandibular tuberosity in the ramus. But if we really would look, we would see that the x-ray is coming this way, and the mandibular tuberosity is lingual to the ascending ramus. So this idea that a tooth could be growing in the ramus is ridiculous. The ramus is outside of that. The tooth is growing in the tuberosity. Just like in the maxilla, we see the end of it. This little bone up here, this little piece right here, okay, is the coronoid process. Coronoid process is really there to attach the temporalis muscle. Right? So if you cut the temporalis, the origin is in the temporal fossa. The insertion is on the coronoid process. So if you paralyze that muscle, which part of the mandible would be affected in terms of its morphology and its growth? The coronoid process, exactly. Because bone is adaptive. So that's a good question. And so if that ends up on the midterm or ends up on something, that's a good one to remember, that understand how these parts fit together and understand what might change. Now, we talked briefly last time about number 1. And now we're going to expand on that. So this lecture is really going to be all about the condyle of the mandible, So what I want to do is I'm going to pass around some mandibles. I won't throw them too far because I hit somebody with a mandible a few years ago and it was a problem. They weren't lucky. So, hit him right in the eye. It's terrible. And it looked like this. All right. Just kidding. All right. Here, I'm just going to pass around some. And some of these mandibles have are only half a mandible. That's okay. You can imagine. I'm passing them out. Right. There you go. Okay. Great. All right. Anyone else? Baby mandible. All right. So, what I want you to notice about these mandibles is that the condyles, no 2 are alike. No 2 condyles, when you pass it around, no 2 condyles, and if you look at the left and the right condyle, and if you look at them carefully, you'll see slight differences even in the right and the left condyle. Okay? So this is one that's bilateral. So, the condyle now is very, very specialized joint. So not only do we have the most complicated bone to deal with, we also have the most complicated joint to deal with. In fact, in dentistry, a lot of times we just call it the joint, right? The joint. But if you go outside here, now we're going to start to get into interdisciplinary education. So we have to not say stuff that, if we're only with our group, we can say the joint, we all know what we're talking about, okay? But if you go over, you're talking to the nursing school or the medical school, and you talk about the joint, they're going to go, well, there's lots of joints in the body. And say, well, we're talking about the most important one, which is the temporomandibular joint. So if now I take just this condyle, and I look at it here, and I'm taking down the piece that I had there, redrawing it bigger so you can see it. Okay, and this is what's going around in terms of that. Now, the condyle itself is pretty complicated. The condyle itself is pretty complicated. On the outside surface, there's a fibrocartilage. Now, fibrocartilage is just like what it sounds. It's sort of like hyaline cartilage, only instead of just amorphous ground substance, it has more fibers. So again, it's a histologic definition. Now, knowing what you know about the human body, and knowing what you already know about structural tissues, the cartilage and bone, knowing that cartilage is there for flexible support and to resist pressure. In this fibrocartilage, if you were going to look at it under the microscope, would you expect that there would be really densely packed cells, or would you expect that there'd be just a few cells and lots of fibers, okay? Well, we know that the fibers are the cushion part, right? So when we see articular cartilages, anytime we see that, we expect few cells and lots of other stuff, okay? And that's exactly what we have in the condyle. Few cells, lots of other stuff. As you get deeper into the condyle, as you start to look deeper in, into the condyle, you notice that the end of the condyle has various amounts of growth cartilage. So there's fibrocartilage and growth cartilage next to each other. Okay? Fibrocartilage is near the surface, and the growth cartilage is down a little bit deeper. Okay? So in the condyles that are going around, if you have a really young condyle, like this one, you know, where it's really young like that, you can see a line around there where the bone is, and you can see, like, if you look at it, you'll see it's like not like, it's sort of pebbly, it's not super dense right here, it's not corticized, okay, like it is over here. That's because there was a cartilage cap sitting on that. So there's a cartilage cap sitting on that. Anyone that has a young one, you'll see that there's a cartilage cap that's sitting here. The cartilage cap has growth cartilage, and growth cartilage is characterized by what? Lots of cells, right? Lots of cells. And so as you start to get to the edge, now there's going to be less cells and more fibers until you finally get to the outside edge where it's almost all fibers and just a few cells. But remember that all the cells are cartilage cells. All the cells are cartilage cells. It's just the way they're arranged that makes the structural difference, okay? Sometimes that gets confusing. You know, you learn about chondrocytes, you learn about chondroblasts, you learn about cartilage, and then the histologists get in there and they say there's hyaline cartilage and there's growth cartilage and there's fibrocartilage and all these things. All they're talking about is the structure, the way it looks, it's microstructure. The microstructure. So you don't look at microscopes anymore now, you guys look on your computer tablets or whatever, right? But it's the same deal. You're looking at what's the microanatomy, what's the microstructure of tissues. And because the microstructure looked different, histologists came up with different words for it. Okay, and that's confusing when you first start to learn about the human body, because we've got these things where we talk about the cartilage that has its name from its histologic appearance, and then we have this problem of bone. Remember that we talk about it not only its histologic appearance, we talk about its embryologic origin. So some bone starts as cartilage, doesn't it? Some bones start as cartilage. If it starts as cartilage and then is turned into bone, we have a name for that. That doesn't have anything to do with the way it looks in the microscope. It has only to do with what we know, how it got there. So if a bone, part of a bone, and the mandible is certainly a bone, okay, and we know that the condyle has a cartilage, and we know that the condylar cartilage is capable of dividing, because it's a growth cartilage, right? So we know growth cartilage is capable of interstitial growth. Okay? And we know that when you look at these adult mandibles, if you've got, here's another baby one here. So you look at a mandible like this. This would have a big piece of cartilage on it. And the other thing that we talked about this, always actually fooled around with the end of this. When we talked about how the mandible is really flat like this, because mostly the movement was back and forth like this, and then as you get older, you start to chew, and then eventually you get to the adult, and that's why we have the articulator. The articulator is man's attempt to simulate movement of the mandible, right? That's why you have an articulator. I don't know if you knew that. Do they start with that, like saying that the articulator is the mandible, right? It's the mandible. And then the dental cast is the teeth part. But it doesn't grow, and it doesn't change, and so it's not dynamic like a human. But it's like for making stuff, especially they started with dentures, right? So most old people don't grow that much. They grow slow. They grow, but they grow slow. So the fact that the articulator doesn't grow doesn't matter if you're using it on someone who's like 40 or 50 or 60 years old. Now, a 6-year-old or a 10-year-old almost makes no sense, because it's changing so fast that you just get the articulator set up, and 6 months later it's all different. Which is why a lot of times people that work with kids don't use articulators, because the person's changing faster than the articulator, whereas it's good for older folks. So you get up here, you can start with that one. Okay, so because part of the condyle here starts as cartilage and then it's converted to bone, a common board question will be, is the mandible formed by endochondral ossification? And the answer to that is part of it is. Part of it is. Certainly, if you look at that, and some of these little, who's got a mandible that's like has no teeth, but it's a baby one, and then hold up one of the other ones. So hold that one up, the big one, the bigger one. And who's got the baby one? Okay, so here's a baby one. Here, you hold it up. Okay, so for this bone to change into that bone, I can tell you some of the cartilage